Sure. But anyway, you remember in the beginning, I said whatever mom takes in is important. Whatever mom eats, or she doesn't eat, or she smokes, or she does drugs, all these affect the fetus. Okay. Because the fetus is connected to mom, right? So, and everything except for a large molecule of insulin, everything goes through transplacental. That means goes what? Across the placenta, go right to baby. So if mom took drugs, the opiates, baby's gonna come out looking kind of funny and have neonatal abstinence syndrome. Okay, it's just like any other person coming off drugs. It's so heart wrenching. I honestly can tell you that because I have taken care of these babies. Okay, and so we're going to talk about, so write that down, neonatal abstinence syndrome. That's a big topic. The phototherapy we'll talk about with jaundice. Pathological jaundice is jaundice that occurs within the first 24 hours of life. And physiological jaundice is jaundice that happens after about 3 days. Now, write this down. It's never good for pathological jaundice. No, because there's something wrong with the baby's liver. Okay, so we'll go over that. So that's the phototherapy that we're going to go. We're going to go over spina bifida. We're going to go over Meconium aspiration syndrome. You see, we already had that. See, I went into detail about that already, but we're going to go over it again. Hyperbilirubinemia, that just means is an excess amount of bilirubin that is circulating in the baby's blood. That is never good because that causes jaundice. Okay. We're going to talk about hydrocephalus, another open neural tube defect. Okay. Again, what can mom take that we know that can help prevent these two? An open neural tube defect. Anybody?
Acid.
Folic acid. Yeah. Well, that was great research when that came out. I was really into that research because that we need it. Okay. Yeah. I've taken care of children at the Texas Children's Hospital that have spina bifida. It's just broke my heart. I can't do pediatrics because I go home crying all the time, to be very honest with you. And then, of course, we got clubfoot and some other kind of malformations. So, I've seen clubfoot feet. I've seen where the legs just go in, but we can correct some of those birth defects. All righty, everybody back? Let me see. Yep, it's 3:12. So everybody have your camera back on. And I know you got your pencils and paper. And I'm going to go ahead and share my screen. And let's go ahead and talk about this chapter. Okay. Here we go. All righty. So chapter 14, the newborn with perinatal injury or congenital malformation. These are our objectives for this section. So we're going to talk about some common disorders of the newborn. We're going to talk about hydrocephalus and the spina bifida. Well, birth defects. Well, we're never happy with a birth defect, are we? But these are abnormalities that are apparent at birth. So they could be structure, function, and metabolism. And these are the three areas that they're kind of categorized in. So what happens to be a congenital malformation? That means that they're what? You're born with it, okay? So you could have inborn errors of metabolism, and we're going to talk about that. Disorders of the blood. We try to keep that erythroblastosis fetalis down a little bit by giving mom Rogaine. Remember we talked about Rogaine, how important it was? Okay. And then some chromosome anomalies, such as Down syndrome. And then the one I hate the most is the perinatal injuries. We try very hard in labor and delivery to make sure that this doesn't happen. Very hard. So there's a great organization. It's called the March of Dimes. And these are, they do a lot of good for moms that have babies that have some problems. And so if you ever want to get involved with the March of Dimes, that would be great. So I have question 1. An active and efficient participation in prenatal care can significantly decrease the risk of congenital anomalies. What do you think?
True.
Yes, it is definitely true. Mm-hmm. And that's when I said, remember, in the very beginning, I love to get women in before they get pregnant. And that's called preconception counseling, right? And I like to get them all in, get them on vitamins and folic acid, is because I want to keep the risk down. Okay. My diabetics, they have a tendency to have more congenital anomalies. And so I like to get my type 1 diabetic patients in early also. So, okay, good. All right. That's why the importance of prenatal care is so. This is a chapter that shows you that the importance of prenatal care, it really is there. Okay, so we can have some malformations that are at birth on the nervous system. So these are your neural tube defects, so hydrocephalus and spina bifida. And what that means is that there's failure of the neural tube to close either at the head, the cranium, or the caudal end of the spinal cord. So it's either on the top or the bottom. This whole spinal cord, it fails during the embryonic time to close. And so that's why we want to get them in quickly. All my ladies like to get them in pre-conception. Okay, hydrocephalus. So write it down, hydrocephalus. What it means is too much cerebral spinal fluid within the ventricles of the brain. Okay? So in the ventricles of the brain, there's too much fluid. So what happens if you have too much fluid in the brain? It causes pressure changes in the brain. Yeah, there's too much fluid. It shouldn't be there. And what happens, it increases in the head size. So think about it. You got more cerebral spinal fluid, and therefore it has to go somewhere. It's going to keep growing. It's not being drained properly. So your head size of the newborn is big. Write that down. Increase in head size. And what happens is an imbalance between the production and the absorption of the cerebral spinal fluid, because the formation of the ventricles of the brain are not correct. So I think I have a great picture here too. I'll get to that. So what happens? You have an obstruction, and you can get such infection, and you can also have a hemorrhage. So let me go on here. I mean, your picture has a really good picture also. Let me go here. Here, let me go down here to the picture, because the picture is like 1,000 words. So you can see the big head. Okay. And these poor guys, when they try to feed, their head is so high that you have to support the head. So write that down, because that's a really important nursing intervention.
I have a question.
Yes, sure.
So babies with hydrocephalus, are they like developmentally delayed, or is their head just big?
It's all according to the stimulation of the child, because hydrocephalus, they function very well. I know someone who is 40 years old that was born with hydrocephalus. Now, granted, she has to take like Dilantin for episodes that can happen because of the hydrocephalus, such as a seizure, you know. But they do very well. They function. It might not be at a high normal functioning, but it is not as low as a Down syndrome functioning. They can function, but there is limitation. Yes, there is. Does that answer your question, Barbara?
Yes.
Okay. All righty. So what I want you to see is that the baby's head is very shiny. It's very large. And main thing is these babies have to eat. And just think if you had a head full of fluid and you know, it's the weight. Think of that. There's the weight. Now there's a great picture on page 339 in your textbook of a baby with an enlarged head. And you can see how heavy that head is for that baby. Yeah. And so nursing intervention would be definitely to support the head during the feeding. Okay, let me go back here. So what things that you would see would be the increase in the size of the head. That's very classic. And the cranial sutures, you know, those cranial sutures I talked about in the middle, going down the middle of the head, the cranium, well, they separate to accommodate an enlarging mass. Yeah, could you think, you know, you got fluid in the head, you got the suture line, and they had to accommodate this extra fluid so the sutures would begin to really separate. So that's why we say you gotta be very careful with infection, because they can get infection very easily. And I said the scalp is shiny, and the veins, yeah, you can see the veins in their head very easily. You can see that on the picture, figure 14.2. You can see that the baby's the veins in his head. Yeah. Now, it is discerning to see this, because you know you don't want to see babies having this kind of malformation.
I have another question.
Sure.
So they always gonna have a big head, like they ain't gonna grow into it?
No, no, because I'm going to talk about what we're going to do for this baby.
Okay.
They're going to do surgery to put in a shunt.
Okay.
And the shunt will go up into the ventricle, and it goes like behind the ear. They have like a little pump, and then it goes down into the peritoneal cavity. Now with children, they have to have multiple surgeries as they grow, because this has to be, you know, fitted for their body. But that's how they live, and it works very well. Like I said, the longevity is there. You know, you have correct medication, you have the different shunts, you can mature to an advanced age. Such, I mean, I have my one of my friends, I mean, she's 40 years old. She does very well. But she knows her limitations. And she's, like I said, she's doing well. But the main thing is that they have to, from time to time, sometimes get the shunt pumped. And in the hospital, you have one of these patients, the doctor will order that, and you just read how to pump the shunt. So you want to make sure that it doesn't get clogged or anything. Okay. It works very well. So if I asked you a little brain teaser, which assessment finding will the nurse expect for an infant diagnosed with hydrocephalus? Which one of those?
Two.
Two.
Two. Yeah, correct. Correct. Now, you are correct. Large and rapidly growing head. Now, the first, number one, the protruding tongue with a short, thick neck is a Down syndrome baby. The inward turning of the ankle and foot, that's Clubfoot baby. Yeah, yeah. And the hairy little patch in the lumbar sacral region, would be your spina bifida, your spina bifida occulta. So those are things we're going to talk about. Good. So these are your symptoms of increasing intracranial pressure that you would see. Because of the increased pressure, you're going to have increased blood pressure, decrease in the pulse, decrease in respiration. Now, with babies, they have a high-pitched cry. They definitely have unequal pupil size or response to light when you have intracranial pressure. That makes sense. And the big one for babies that I want you to take note to and write down is bulging fontanelles in infants. That's how we know if there's problems, because the fontanelles should never be bulging. That's what babies are born, we check the fontanelle. Remember the anterior and the posterior. They should not be bulging. And the same thing on the other end of the spectrum, they shouldn't be sunken in either, because that means your baby is very dehydrated. But for intracranial pressure, we check the fontanelles, and if they're bulging, that's not a good sign. And that's when we deal with infants. Now, in children, they can have headaches due to the closed cranial sutures, irritability or lethargic, and vomiting. And whenever a child or baby is a poor feeder, there's a problem. There's definitely a problem. Okay. So how are we going to take care of this? They put in the shunt, like I just said. And we do it under surgery. And what it does, it definitely removes that cerebral spinal fluid, that SS amount, and it goes into the peritoneal cavity. Now, again, remember I said you have to worry about what? Infection. Yeah, infection. And this is just like your picture in your book, because that was on page 339. And it shows you exactly where the shunt goes. So here's your ventricles. Let me get my little mousey here. Here's a ventricle. You put it into the ventricle, goes right behind the ear. Here's your pump, and it goes right down into the peritoneal cavity. Okay. Now, as the baby grows, this shunt has to be removed and replaced. So that's why it's so disheartening when you see a baby like that. And so preoperatively, you have to make sure you support the head. You have to always, the baby can't lay there in one position, just like anything else. Your geriatric patient or any patient, med-surg patient, you always have to change position, because why? You have to prevent skin breakdown. Because when skin breaks down, what happens? You're open for infection. That's what any patient. Support the head at all times, especially when feeding. And we do measure the head circumference. So when we do our vital signs, that's another thing that you do, is you measure the head, because you want to see if the head is getting bigger and bigger, and how much bigger on a daily basis. Now, post-operatively, we're going to look for signs of increasing intracranial pressure that we just went over. Protect from infection, always. Remember I said that? Depress the shunt pump as ordered by surgeon. Yeah, he'll write a order for that pump, and you follow the doctor's order on that. And then position dependent upon, multiple factors. And of course, you want to assess the baby for pain. We use the pain scale of the children. On this one, parent education, you're teaching parents how to pump the shunt. A lot of parents are very scared, but you tell them why, and they get very good at it. When the shunt malfunctions, especially in the older child, remember I said they can have headaches. They get very lethargic, and they have changes in their level of consciousness. So that would be in an older child that you would see that. With the baby, you would hear the high-pitched cry. Okay, so I think we went ahead and went through hydrocephalus. And let's go on now and speak about spina bifida, another open neural tube defect. And in your book, on page 341, figure 14.4, there's the different types of spina bifida. So you have like the spina bifida occulta, which is the first one. And what you see on that one would be a little tuft of hair that's right at the bottom right here. Okay. That's the sign because occulta means you can't see it. So we can't see this, but because that little tuft of hair is there, we know there's a problem. Now with the next one, you want to see, now you can see here that this is the spina bifida cysta meningeal seal. So you can see where the meninges are protruding, and you can see the defect in the Bode canal. Okay. Now you can see this one, and this one here. The last one is where you have the spina bifida cysta meningeal myocele. This is when the meninges are protruding. The spinal cord itself is protruding, and there's a defect in the Bode canal. This is the worst, guys. Okay. But on this one and this one, you always want to protect the sac. See this? Always want to protect the sac because it's outside the body. And anytime you have an organ that's outside the body, you have to put a sterile, wet towel on it. Okay. So I would put a wet, sterile, maybe saline towel around it to protect the sac. Okay. You don't want that sac to dry out. Okay. Now there's two types, and we just talked about them. The occulta is the hidden one. That's where I would put down the little tuft of hair to remind you. And the cysta is the sac or the cyst. And we showed you those. What happens is that, you have to try to close that up. They go to surgery, try to close that up. A lot of children are affected below the waist on these. They have their bowel and their bladder, their sphincters they can't control it.
Okay, and just to verify, you said in the occulta, you will see the hair.
Okay. Yeah, the little tuft of hair. And I can just go to page 341 in your textbook, and there's a good picture on the tuft of hair right at the sacrum. You can see it. Okay. Got a little hairy patch. Yeah. Yeah. And that gives us a clue because we can't see because there's no protrusion, like the other ones, the meningeal myocele and all that, that has a protrusion coming out. See here, and see here. We can see that when the baby's born, but this one is not. You can't see that little tuft of hair. I mean, you can't see that spinal, the spinal. Okay. Please don't submit your homework while we're online, you're in live lecture, okay? Yeah, I do get notifications. So you don't want to do that while you're supposed to be listening. Okay, so let's go on here. So again, we have this tuft of hair, which tells us we have the occulta. Oh yeah, I do have a picture. Here it is right here. So here you go. Here's a little tuft of hair. So that would give us a clue that what we're dealing with a child that's got spina bifida. Yeah.
So the hair stay right there all the time because that's a big kid.
Pardon?
The hair. So if they got hair or whatever right there, it stay like that forever?
Yeah, yeah. And what it would. It's not gonna go away because it's the occulta, but they're gonna have limitations, but at least oh, what happened here? Hold on. Okay. Yeah, it will be there. Yeah. It sometimes it could be a dimple even. Then if you see that, you would have the baby, examined and tested, okay? But this gives us a clue as to something's going on. You can't see it. Okay. What happens is they have disturbances of the bowel and bladder sphincter functioning. Okay. So they have progressive disturbance of their gait. Okay. All right. So this one here, I made a slide for you guys. It's meningeal seal. It contains the portion of the membranes and the cerebral spinal fluid. The size will vary. Now, the worst one is the meningeomyelocele. It's more serious protrusion of the membranes and spinal cord through the opening. What happens with these babies, they do have paralysis of the lower extremity. They have no control over the bladder or the bowel. And they also can have another complication along with it is the hydrocephalus. So this child has a lot of problems. And like I said, I took care of quite a bit of spina bifida back in the 90s at Texas Children's Hospital. And they had no control of the bowel bladder. Yeah. It's just very sad.
Is it always bowel and bladder? Can it be one or the other in some cases?
Well, yeah, it could be one or the other, but if you have, this protrusion of the meninges and the spinal cord, and what we do is the surgeons go back and try to put it back in. It's never the same. So you're going to have some kind of paralysis of the lower extremities, and they have no control over either one of them. They'll have poor or no control whatsoever. Yeah. Now, if mom just takes that folic acid, like we said, it can prevent these two from happening. Any open neural tube defect. Okay. All righty. Here too, I just put in the disclaimer here too, is if there's no weakness of the legs or the sphincter involvement, surgical correction is performed with excellent results. So if they have just the meningeal seal, you can get better control. But if you get the meningeal myelocele, where you have the spinal cord barber itself coming out, and the meninges are protruding, you got more serious problems. So it's all according to what level the injury has occurred to. Does that make sense?
Mm-hmm.
Okay. So again, you got surgical intervention. And the main thing too is you don't want to ever keep anything open on the body. So we're going to go ahead, because when you have something open on the body, it can get infected. Okay. So we went ahead and close it up so they don't get infected. Now, a lot of children, when they have the meningeal myelocele, have to go to a special place. It's called habilitation, like rehabilitation. This is habilitation. And this is a place where, they learn to, and parents learn to take care of the child and help them with skin, because if they're incontinent of urine and feces, the skin breaks down, they can get infection. So they go to this kind of place, and it's meant for these kind of patients. Yeah. Okay. All right. And habilitation is that your child is disabled from birth, and they try to, like I said, minimize the child's disability. So they focus on positives. So if your child is like paralyzed from the waist down, they have no control or anything, they're okay from the waist up. Okay. So you try to constructively, build up, make sure it gets, muscles in the upper part of the arms, try to, use that. And every effort is made to help the child develop a healthy personality. Yeah. So that he or she may experience a happy and productive life. Main thing is to watch for infection. Okay, so what's our nursing care going to be of our spina bifida? Well, I think I've said this several times already. Prevent infection or injury to the sac. Okay? All right. We always want to do corrective positioning to prevent pressure on the sac. So you have a patient, maybe that you're taking care of the pediatric ward, and the child has this meningomyelocele. So you got a sac in the back there. You want to make sure that you position correctly. Maybe prone, that you don't have this, you don't want to have any pressure on this sac. You gotta make sure that you're exercising all the extremities. You don't want any contractures. It's good skin care, adequate nutrition, and again, always observing. You're doing your charting, and support and educate the parents. You have to support the parents. It is overwhelming to the parents. Overwhelming. Okay, so upon delivery, this little baby now, we're going to place in an incubator. Make sure that he doesn't get cold at all. And this is highlighted for a reason, so take note to it. You're going to put a moist, sterile dressing. Remember I said saline, or it could be an antibiotic solution, but usually saline's good. And then because we want to prevent drying of the sac. That's the main thing. Anything that's outside the body will dry up. It's exposed to air. And then protection from injury and maintenance of a sterile environment for the open lesion. Okay, that is essential, because if they get infected, they get infection, they can kill them. All right, so we want to make sure that that doesn't happen. All righty. Okay. So I think we got that. Again, we're going to always measure. We're going to look at the size and area of the sac. And when we do an assessment on the sac, we're looking for any tears or leakage. Okay, that has to be reported immediately. So that's why we protect the sac, because it can tear. We look at the extremities and we observe for any deformities. And can the child move? Can the child move the leg? Can't. Paralyzed from the waist down. Can the child move the arms? Because spina bifida is also associated with hydrocephalus, we do a head circumference is measured. And then we look at this child's fontanelles on the head, because it gives us a baseline. Because they could have not only spina bifida, but remember, like I said, they could have hydrocephalus. So one of our nursing care of spina bifida baby is life-threatening. Complications can be life-threatening. This kid comes down with meningitis. Again, this is infections, okay? And that's why I said infection is the number one problem. So we can have pneumonia, urinary tract infection easily. So we call in urologists to help us with that, and skin care, because we break down skin care. It goes into what? An infection, and then child gets very sick. Things can be taken care of. Feeding, make sure that the child is fed. If it has hydrocephalus, also along with spina bifida, always support the head. And just like everything else, it's a good potential for a latex allergy, but I think everybody in the world is allergic to latex. Okay, so here's a question. The nurse is caring for an infant born with spina bifida. This child has myelomeningocele. So which intervention will the nurse implement to protect the sac?
Sterile cloth, number two.
Number two. Yeah, you cover with a sterile cloth moistened with saline. You would never put a dry, sterile dressing to the site. We don't use petroleum dressing, and leave it open to air and allow to dry. All you have to do is cover with a sterile cloth, moistened with saline.
Now, how long after a baby is born with spina bifida would they like surgically, fix this protruding sac or whatever?
Yeah, they try to do it pretty soon. It's not like the cleft lip and cleft palate where we wait. We try to fix it because it can affect the child.
Okay.
Yeah. Okay, so the next categories we're going to go into now. We're going to discuss about the cleft lip and cleft palate. And then we're going to look over hip dysplasia and some dietary needs of the baby born with or prevent PKU. Okay, so let's go into the cleft lip. I think everybody's pretty familiar with cleft lip, and what it is just is an opening in the upper lip. Now go to page 343 in your textbook, and there's a really good picture of a cleft lip, and you can see that. And it's just that it didn't form right during the embryonic development. Okay, this is when it's from what, the very very beginning. It goes what, from the beginning, week 1 to what, week 8, right? This is when the embryo is really developing, and so you can see how all this comes into play when the nasal processes kind of come together and they unite. Now, during the embryonic development, because it's up from week 1 to week 8, a lot of women don't even know they're pregnant, correct? So that's why I always said I'd like to get them in before they get pregnant, preconception counseling. But, we try to get them on things and vitamins quick, because we know that every minute counts, and especially in the embryonic development. In some cases are hereditary. Some countries have it more than others. And then some can be caused by environmental teratogens can happen. You see it more often in boys than girls. I do not know why, but that's what this research shows. And so here's our baby. And just know that during the embryonic stage, the nasal processes just did not close properly. All right. So infection is another big problem with this baby. Also, this poor baby, you know how babies like to suck, right? Well, this baby, we can't let this baby sucking. Okay. So this one, they like to repair by 3 months of age. Now that could be a really long 3 months with that mom, okay? Because they don't want the baby to scratch the lips or anything, and a special syringe or bottle may be needed until the surgery has occurred. Yeah, because he can't suck, right? He can't get the liquid out of the nipple. So a special syringe or bottle has to be done to push that milk into the baby. Okay. So would that be a long 3 months? Yes, a long 3 months for those moms. Okay. And you have to make sure that after surgery that you don't have this baby sucking and crying. Now, is that hard to do? It sure is. Because infants get very much an emotional enjoyment out of sucking. And then how do infants communicate to their mommies? They communicate through crying. So you can't have a child sucking and crying. Okay. And you want to make sure that you don't have any injury to the operative area. Is because especially on a cleft lip, that's going to be all like cosmetic. So you make sure that it stays really good, it stays clean, and you want to prevent infection and scarring, because you can see people who've had a problem with a cleft lip and maybe they had some problems and maybe it got irritated during the healing process and you can see a bad scar. Okay, so we want to prevent this. And you do some gentle cleansing of the suture lines to prevent crust from forming. Now, infants need to have their emotional needs met. So you could do maybe some cuddling and get multi-swaddling to make sure that they know that they're being what? They're being cared for. They get their emotions, that they feel love. That's what I'm looking for. And then you provide appropriate pain relief measures also. Babies, you don't want the baby crying, right? Okay, so how are we going to feed this baby? Well, you're going to feed it with a medicine dropper until the wound is completely healed. Okay, and about 1 to 2 weeks. The more you pay attention to the post-op care of this baby, the prettier the scar is going to be. Okay, we don't want a scar. Okay, and then you cleanse them out by giving the infant small amounts of sterile water at the end of each feeding. Make sure after eating, you're giving the syringe and pushing that formula through. Oh, is there a question? Okay. Then you just want to cleanse them out by giving the infant small amounts of sterile water. Make sure, what am I doing here when I'm cleansing them out? I'm keeping from infection. Remember, infection is never good. Okay. All righty. Okay. So again, we're going to go from cleft lip to cleft palate. Now you just see a nurse. I don't know if you've been in a delivery room or anything, but we check the root in the hard palate and the baby as soon as the babies are born. So you can see that. And then when you can feel an opening there, then you could have a possibility of a cleft palate. And what that is the failure of the hard palate to come together at the midline during the 7 to 12 week of gestation. So 7 to 12 weeks, you're already in the fetal development stage. So here you're having a little long, the cleft lip was during the embryonic. The cleft palate could be happening during the fetal. So hopefully she's in by this time, about 7th week, and she's already started on some vitamins so that the hard palate will fuse together at the midline like it's supposed to. Now these babies, because there's a passageway between the nasal pharynx and the nose. So touch your nasal pharynx and the nose. And if these passageways are open, then they are at high risk for respiratory infection and, get this, middle ear infection. So do I have it highlighted for a reason? Yeah, I do. Okay. So they are at increased risk of infection of the respiratory tract and the middle ear. They get a lot of earaches, these kids. Okay. So what's your goal of therapy? Well, surgery. Let me see here. Yeah. Goal is surgery. Yeah. Bring it together.
So cleft palate and cleft lip, they don't look the same either?
No. The lip is on the outside, which would be the lip. And the palate, you take your finger and you can put it on your palate. It's the hard surface of the roof of the mouth. And when that's open, because it just didn't close during the 7 to 12 week, and it's open. And so if that's open, then anything the baby takes in can go, into it can go down the trachea into the lungs, or it can go out through the sinuses out to the eustachian tube in the ear and can get earaches. That's why they are more prone to a middle ear infection.
I have a question.
Sure.
Can they get both? Can somebody baby have both?
Yeah, they can have both. Yeah, a lot of
Okay.
times in the third kind of world, um, they have exposure to maybe different environmental teratogens, or maybe mom is way under, didn't take the amount of nutrients that she needed, and so they can have both. They can have
And
both.
that's something that can be detected before you have the baby, right?
Pardon?
They don't know about that until after the baby is
Yeah,
born, or is that
yeah,
something?
usually. Yeah, usually. But now, you have these beautiful ultrasounds. I'm thinking of the 4Ds, you really can see the really great features of the fetus. And so for the cleft lip, we can probably see that on ultrasound before birth, so we can get mom ready.
Or
The
probably not
cleft
palate. You probably
palate,
can't see it.
yeah, the cleft palate we couldn't see on ultrasound. But these 4D ultrasounds, they're absolutely fabulous. You can
I'm
see
looking at
everything.
pictures. That's it. Okay,
Yes.
so
Mhm.
um, you fix? Oh, all right. Go ahead. Now,
No, you don't fix them in utero. Is that
no,
what your
no,
next?
no. I meant like, can palate be fixed or no?
Oh yeah, cleft palate. Yeah, that's what we're doing.
Okay,
We can go in there and bring that. We can fuse that together. So we bring
okay,
that together. Yeah, we can do that.
okay.
That's our goal, actually. And so by doing the union of the cleft, you're improving the feeding, speech, because if you have an open palate, it's hard to formalize words. Um, their teeth usually have problems because don't forget, we're born with all the teeth we're going to have. And so if that's dysfunctioning, they can have problems with the teeth coming down. Um,
All right. This is my
so
last question.
mhm.
Is it all? Do they also wait till 3 months to fix that too?
Yeah, sometimes they wait longer. Yeah.
Okay.
Okay. Because you don't want to close it too soon because the baby grows. So then the mouth will also grow. Okay. So along with mom and dad, you have a psychologist, you have a speech therapist, you have a pediatric dentist, because I talked about the teeth, an orthodontist, because the teeth may come in at an angle, and so they're not coming down straight, because don't forget that palate was open. Um, the social worker to help mom and dad, and pediatrician. Those are the team that gonna have to help with this baby. So surgery is, like I said, it's longer. You have to wait between 1 year and 18 months of age, is because of the child's development. And that's hard. That's really hard. That's why these kids are more prone to middle ear infections. That's why if you're bottle feeding this baby, you have a special bottle. You have to make sure that, they're not just propped, and, you have to make sure that baby's actually getting the formula, because again, they can go up into that cleft opening, and it can go out to the ears. And that's why they get such ear infections, middle
So
ear infections.
you can't breastfeed a cleft baby. You have to do a bottle feeding.
Yeah, because they have usually it's a special bottle has to be used.
Okay.
Yeah, it's hard. But now mom can pump and put it in that special bottle. Yeah. So he still can get the benefits, which is great, from breastfeeding, but not from the actual breast, but and mom can pump. Yeah, sure. Probably the best thing. Remember, breast is the best. And nutrition, um, this is post-operative, is no food through the straws to prevent sucking. You don't want nothing that through a straw. No sucking post-operatively. You don't want nothing to harm that closed fusion of the palate. You want it to stay intact. Um, Always clean the mouth with just water to cleanse the mouth after feeding, so that nothing residual up there. Because again, infection. Um, Speech, you always want to encourage the child to talk, but pronounce words correctly and slowly. That's why a speech therapist is good. Now, crying should be avoided when possible, right? So, and play should be the quiet time. Like you don't want him outside, and don't forget we're waiting till like a year, 18 months to get this fixed. So we maybe the baby's already walking and getting into stuff. So be very careful. And you don't want the baby to add like sand or anything, or dirt can get up in there. So maybe just coloring and drawing. You want to keep the child a quiet kind of play, which is not easy because this is a baby who wants to go in and explore the world, but have to be very careful with infection.
All right. This is really my last question.
Okay. Go ahead.
Nobody want to hear crying babies anyway, so I get they're crying babies. Crying should be avoided, but like, why more specific to this disorder?
Well, yeah, because especially post-operatively, you don't want the sutures to open up. So you want to keep crying to be avoided, and two, you want to keep everything kind of. You don't want it. They're going to cry, but you want to avoid whenever possible. Put it that way. But remember the complications: ear infection and tooth decay. So if I was to ask you this question, okay, where's my question? What condition is commonly associated with an infant with a cleft palate? What would you tell me?
Could it be malnutrition?
Okay, so you got problems with feeding. How about infection?
Infection of the ear, right?
Yeah, and that middle ear infection, respiratory infection. These kids can get pneumonia easily. Mm-hmm. All right. Okay, hang in there. I'll give you a break in just a minute. Let's just go over clubfoot real quick. You do see it, unfortunately. The foot, remember, the foot goes in or outward. Okay, it's just in or outward. I'll show you a picture here. See here? You know, sometimes our breech babies, they get into a position, they're in there for 9 months, that their foot can have a deformity because of that. And the most common type is the talipus equatorius. The feet actually turn inward, and then the child actually walks on his toes. And you can see that here. See how the child would walk on, can walk on his toes, or can walk on the outer borders of the feet. I can see that easily. See right there? Here, I get my pointer. Can you all see that?
See here? Fix that right away?
Yeah, well, we're going to correct this. We certainly will. And how are we going to correct this? Whoops.
Surgery, right?
Surgery. Well, gotta put it in the cast. You got to get it in the cast. And I tell you, it's not easy. You can put it in a harness. And in a harness, that's the Plavic harness, or they put on the spica cast. So sometimes they start out with a conservative treatment. It's just according to how it does, but we have to start as soon as possible, because why? The bones and muscles will continue to develop, but they'll develop in an abnormal pattern. Okay. And so you want to get it corrected. The goal is to get the foot corrected. So what we're going to do, you can splint it, or you can put a cast on. It's hard. And what they do is they hold the foot in the correct position. And sometimes they have to take it off and put the cast back on because kids grow. Another real conservative, is passive stretching exercises. But if that does not work, then they go in and about 3 months of age, they'll go and do a surgical intervention.
What's the
Yeah.
odds? What's the chances, or like I guess the like percentage rate of the splint or the cast actually fixing it? Why not just surgically fix it right away?
Because the chances of I've seen a lot of good results from putting a cast on the foot.
Okay.
Yeah. So according to how the care when the child goes home as the care given. Um, again, we have to make sure mom complies with orders. We want to make sure that you prevent skin breakdown. And so, yeah. And you have to review cast care, keeping it clean. Now imagine keeping that clean and you've got maybe a diaper on this child. It's not easy. Go to page 347 and you'll see the pelagic harness that I just talked about. And that's used with infants age 1 to 6 months that's for the position of the flexion and abduction. So you can see that. You can see the spica cast too. Oh, that goes into my hip dysplasia. Sorry about that. All right. All right. I think I'm going to stop here. It's about 4:04 before I go into hip dysplasia. But anyway, let's take a break. Let's see. Let's stop sharing. Okay. So why don't we take what you need? You need about 15 minutes to take a break. Take 15 minutes and
Yes.
then come back. Okay?
Okay.
15, and then I'll start back up. Remember, don't come off Zoom. Stay on Zoom so you get recorded for attendance. Okay? Thank you. Alrighty. Now I know of a friend of mine, her daughter had a baby, and baby had foot such as the one shown on page 345. And what they did very quickly was to put a cast on that baby. Okay. I'm going to let you know she had on several different casts because she's growing. But the outcome is that the little girl is running and jumping just like anybody else. It corrected it. So it can happen. It's just that support for the mom and dad is just number one. Mom and dad have to be supported because it's not an easy thing to go through. Okay. All right. And I also found out that her husband was born with a cleft foot too. That was interesting. All righty, we all back? Am I too soon? Yeah, no, 4:16. Okay. Everybody have a little break? That was a good little break, right? Okay, so let's go on. We got to get through everything. So let's go on. Let's talk about hip dysplasia. So what you see is that you see the full. So this leg here, you can see how when we put the leg out, we can actually hear like a clicking in the hip. That's because the top of the femur is not going into the acetabulum very well. So you have that problem. Let me see here. Yeah, okay. Here, a lot of times you see this at the doctor's office, usually about a couple months of age, the baby's a couple months of age, you see how this side does not look anything like this side. Okay. And then you have, again, you see the leg here is much shorter than this one. Everything should be symmetrical, all right? If it's not, then you have what we call hip dysplasia. And it can be, partial or complete. So when the infant's like in a prone position, one buttocks appears higher than the other, okay? Higher, right, than the other, okay? And so what I said was the head of the femur, it can be partially or completely displaced. Now, it happens a lot more in girls than boys. And it becomes apparent especially when the baby begins walking. But I can tell you, the pediatrician will do these kind of tests on babies. And I've seen them, the pediatrician do them in the nursery. Is they're looking to hear if they can hear any kind of clicking noise, because it can be worked on. We can help it here. So the most reliable sign is the limited abduction, okay, which means what? Going away from of the leg on the effective side. Okay, so again, on the, this one right here on the affected side. Okay. All right. So there's two types. I told you about the clicking. That's called the Ortolani sign. And the healthcare provider can actually feel and hear the femoral head slip back into the acetabulum under gentle pressure. We shouldn't be able to do that. Then you have, and you can hear the clicking. It really is, you can hear it. Now the Barlow's test, upon abduction, which means bring it together, or extension of the hips, you may feel that this dislocation actually occur. The pediatricians do this, okay? Nurses, we do not do that. Okay. So how are we gonna how are we going to get this? This is where I was talking about the pelvic harness. This is where on page 347, a figure 14.10, you have a smiley baby in a pelvic harness. And it's used with infants like age 1 to 6 months to maintain the hips in a position of flexion and abduction, either way. Okay. So what you're trying to do is we're trying to keep the head of the femur within the hip socket. All right. Not easy. The hips are what we call maintain a constant flexion and abduction for 4 to 8 weeks. Not easy. And you want to get that femur into that acetabulum and keep it there so it don't come out anymore. So you use the pelvic harness. Okay. And here I have a picture. Here's our smiley baby right from your book. Okay. Yeah. Not easy. Now this baby is in a cast, spike cast. And sometimes you see a lot of, if you're in the hospital and you're on the pediatric ward, you see the babies in the little wagon. That's the best way to transport that kind of baby. It's in a little wagon. So what you want to do is, what's your nursing care of these babies? Well, you look at the neurovascular assessment of the affected extremities. So you're making sure that everything, color, the toes and everything is good. You might want to place some firm plastic covered pillows beneath the curves of the cast for support. That you can see that in this picture too. Let me show you here. This picture right there. Okay. For a child who, an older child, you may want to use what we call a fractured bedpan. Those are, have either easy to get under a person rather than a, traditional bedpan. We use fractured bedpans on the orthopedic floor. Okay, and then head of the bed should be slightly elevated to help drain any body fluids away from the cast. Okay, you don't want it to be, going back up in the cast. Now, remember, these are babies, these are children, and they're in a spica cast. So, what do children do when they have a cast on? They like to hide their toys, right? So make sure that the toys they're not small enough to hide in the cast. They should not be given to a child. A small should never be given to a child because they hide in the cast. They actually put their toys inside the cast, and so that's never good. Okay, and we want to make sure that we meet the child's needs every day. And a special wagon. Remember I showed you that special wagon with pillows for support. It's one of the safest ways to transport a child in a spica cast. Yeah, and then here's our little wagon right here. And this is the best way to transport a child that's in the spica cast. So can you see a child putting stuff down the cast? They think it's cute. They can hide their little toys in there. That's not going to work, right? No. Okay. All righty. So now we're going to go into inborn errors of metabolism. And this involves a genetic defect that may not be apparent until after birth. The big one I'm thinking about is like PKU. So we're going to go ahead and discuss about those. The symptoms report would include, remember, a poor feeder. Always. Children that are sick will not eat. If they don't eat, they become very lethargic. They also can get what we call hypotonia. They lose their tone. And then they could have a unique odor to body or urine. And a big one is the maple syrup one. We'll go over that. And of course, tachypnea. Okay, so the first one I want to talk about is phytoketonuria. And that is the official term for we call PKU. And what happens is that in the body's not able to break down phenolphthalein, which is an amino acid that's essential to life. And it's found, everybody, in protein. Okay, it's found in all protein foods. So someone that cannot break down protein can get a condition such as PKU because they eat protein, but their body can't break it down. The phenolphthalein that's in the protein, it builds up. And when it builds up, it can be detrimental to the baby, okay? So these are infants that are unable to digest, again, the essential acid. So again, phenolphthalein accumulates in the blood. Now it's found in the urine within the first week of life. But you want to find it before that week is up, before that week. So what we do is we'll do a blood test before the baby leaves. Now, write this down. You cannot do a PKU right after birth because the baby hasn't had any protein. Think about it. So we usually wait till about 2 to 3 days. Usually the third day is the best. And then we'll do a blood test. And because blood is faster, we can see it because it accumulates in the blood. And you want to do it quickly because you don't want to be giving this baby protein if the baby cannot break down the phenolphthalein in the protein. Because what happens, it accumulates and it can cause mental retardation. And that's why we want to find it in the 3 days and not wait to the first week of life, because it could have already caused damage by the first week of life, at the end of the first week of life. So that's why we do it as a blood test. Now, every baby in the United States gets a PKU test before going home. Every baby. It's a law. Because we can prevent severe mental retardation by doing a simple little test to make sure this baby's able to break down this essential acid, the phenolphthalein. Okay. Now, these babies that are PKU, they do appear normal at birth, and they can have delayed development about 4 to 6 months. And these babies are babies that have failure to thrive. They don't grow. They can have skin conditions. And this child, write down, they can have a musty odor. That's PKU. And I told you by the time the urine test is positive, brain damage has already occurred. So that's why at about 3 days of age, we go ahead and do PKU. And very, very important. Even if mom wants to go home in 24 hours, she has to bring the baby back. Because we do explain to them that, this baby may look just normal at birth, but it's because the metabolism, there's a problem with that. They can't break down that phenolphthalein. So, and then you tell them that they're at risk for mental retardation. They bring those babies back. Now, the test that we do for PKU is called the Guthrie test. And like I told you, it should be done within 72 hours of birth. It has to wait. You can't do it before 48 hours because the baby, again, has to take in protein. So that's the main thing. I mean, you may see a little test question on that, but that's a pretty good test question. Okay, so what are you gonna do? Well, you gotta make sure that if baby is positive for this, that they go on a special formula. And the most popular one for infants is lofenalac. So it's LOFENALAC. Okay. And This food that provides enough, it gives them enough protein for growth and tissue repair, but not enough to cause mental retardation. Okay. And we're always going to have frequent evaluation of the blood phytophylline. They have to be monitored. So they have dietary management. They're going to have management of the blood phytophylline levels. And for infants, they're going to be on low phenolic. Okay. And you have to explain that to mommies because they're going to go to a dietitian because parents have to have guidance support. They have genetic counseling could also be indicated. And then I told you about follow-up tests with blood tests and teach parents the importance of reading food labels. Okay, that's what I heard something. Okay. So this is a good one to remember. Children with PKU must always avoid the sweetener aspartame. But is aspartame good for anybody? No, it's not good for anybody because when it's converted to phytophylline in the body, when it breaks down NutraSweet, it's converted to phytophylline in the body. So again, that was part of a inborn metabolism defect. Now, another defect is of the branch chain amino acids, and that's that maple syrup urine test. Okay. This one, the baby's urine will actually smell very sweet. And so have you ever had maple syrup? Ever smell maple syrup like when you have your pancakes? That's what it kind of smells like. And it can do cerebral degeneration, and they can die within 2 weeks if not treated. Is that pretty bad? It's very bad because they basically go into like ketoacidosis, and so you have to pick up on that. So again, these babies appear healthy at birth, but problems will soon develop. They will be very difficult to feed. You know that moral reflex where, this is also called the startle reflex, where the arms go out? They don't have that. So that's important to pick up in the very beginning. These babies have very low body tone, hypotonia, irregular respirations. And these babies are prone to seizures. So what are you going to see? So you can have urine, sweat, and earwax that smells like maple syrup. It's sweet odor. And that's caused, like I said, by ketoacidosis. It causes fruity odor of the breath. Don't you see that in adults too that have problems and you smell like have a fruity odor of the breath? They're in ketoacidosis. Diagnosis is confirmed by blood and urine tests. Not easy. So how are you going to treat? What's your treatment and nursing care? Is you're going to remove the amino acids and the metabolites from the body tissue. You might have to have some peritoneal dialysis to decrease serum levels. And of course, hydration helps. Now, it's a lifelong diet, low in amino acids, leucine, isoleucine, and valine. Okay, it's lifelong diet. Just like PKU, it's a lifelong diet alteration. Okay. You may have exacerbations where they're usually related to a degree of abnormality, maybe because the leucine level goes up, and they have to be really monitored. So when it goes up, they may have to go under some peritoneal dialysis. Infection for these children can be life-threatening, just like for all our other abnormalities. Infection can kill you. Okay, the next area we're going to talk about is called glycosomia, right? Glycemia, that's what? Too much glucose in the blood. So they're unable to use glucose and lactose. What happens is that you have to be able to convert lactose to glucose. Okay. And what happens to these children is that they're missing an enzyme that's needed to help the liver. The liver converts it over from the lactose to glucose. And so they're missing that enzyme. And what happens, you get an increased serum galactose level. And it's also can show up in the blood because as glycemia is in the blood, and then you have galactosuriia, which is in the urine. Okay. Now, if this is untreated, because remember the liver is involved to convert the galactose to glucose. If untreated, it can actually deteriorate the liver, and you can have cirrhosis of the liver. And you probably think, you know, you can equate the cirrhosis of the liver to like an alcoholic, right? But it's because the liver is trying to do this, you know, convert this, and it can't, then the liver can get old faster. It can cause cataracts to children, and worse is mental retardation. Again, just like the other abnormalities can cause mental retardation. Therefore, you know, the galactose is present in milk, is sugar, right, in the form of sugar. And so therefore, early diagnosis is essential. So I would remember a couple things. I would remember that they're unable to convert the galactose to glucose. I remember that the liver is involved with all that. And if it's not treated, the liver can get old. And the worst thing about it, it can cause mental retardation. So we want to get these babies looked at quite quickly. So what about this? It begins abruptly and it just worsens gradually. So what's your early signs that the baby is having problems? Remember, lethargic. Okay, you see how the other problems, they all have the same thing. This one has vomiting, okay? And again, hypotonia, low tone, some diarrhea. And these babies, because they have diarrhea, vomiting, they're not moving around, they have hardly any tone to their body, they are called what we call failure to thrive babies. Okay. And so you worry about these babies. Symptoms begin as the newborn is fed. And then jaundice, they can have jaundice, can be present. And usually that's associated with pathological jaundice, which they have jaundice in the first 24 hours of life. And that's where you can pick it up. So what are you going to do? What's your nursing care? Well, you got to get the milk and the lactose containing products out of the diet. There's no doubt about it. Breastfeeding has to be stopped because there's glucose in the breast milk. So you have lactose-free formula, or these babies are now on soy protein. And these are kind of formulas that are very good for the baby. Parental support and education is essential, so they understand what's going on, because if they don't remember, we could have really a lot of problems, right? And we don't want to have a jaundice. We don't want them to have mental retardation. So we're going to get them quickly. Okay. All right, let's go to our next group of abnormalities. One has to do with chromosomal abnormalities, such as Down syndrome. Then we have a hemolytic disease of the newborn, which is called erythroblastosis fetalis, which, you know, we talked about this already in other chapters, but we'll review it today. Devise a plan of care for a newborn receiving phototherapy. And then we'll look at phototherapy, and we'll look up increase in cranial pressure. That could be from a precipitous delivery. Remember, so you can have increased cranial pressure. And we can discuss the assessment and nursing care of a newborn with macrosomic baby. Okay. All righty. Excuse me. So let's start with Down syndrome. All right. It's a common, unfortunately, it's the most common chromosome abnormality. Risk increases with older moms, advanced maternal age, 35 years or older, and fathers, 55 years or older, because at 55, the sperms start to change configuration. And so that could also change then the configuration of the chromosomes. Remember, you know, the LOX looking chromosomes, there's 2 to each set, right? Okay. When another chromosome doesn't make that configuration like they're supposed to, like little X with just 2, it can tag on to another one. And that's when you get to have that abnormal chromosome analysis, and you see how that happened. And that's what causes these chromosomal abnormalities. So a child can be from mild to severe mental retardation. And then some physical abnormalities can also be shown. Okay. So there's 3 phenotypes, and you have the trisomy 21s. They're most common. So there's 3 number 21 chromosomes instead of the usual 2. Remember, I just said that to you. Because what happened, it just failed to what? Separate. It just tagged onto the other one and said, I'm not going anywhere. I'm going to stay here. And so that's abnormal. Then you have mosaic system. It occurs when both normal and abnormal cells are present. So, and then they tend to be less severely affected in appearance and intelligence. It just it just has a different kind of picture to the chromosomes. And then you have translocation of a chromosome. So what happens is that, like I said, a piece of chromosome in pair 21 breaks away and attaches itself to another chromosome. So the chromosomes have to be, when you do a chromosome analysis, they had to line up just right, okay? And so the best test to do for these moms that are over 35 would be to have a amniocentesis done in the very beginning of pregnancy to do a chromosome analysis. That's the most accurate. Now we can do like a screening. It's called the alpha-feta protein test. And that's done around week 15, sometimes I've seen as high as 18 weeks gestation. And they fill out a form, and then we send off the blood and we do a chromosome analysis. Okay. We don't have to go in the amniotic sac or anything. Again, it's a screening test. So what happens if the screening test comes back positive? Well, we counsel mom and dad, and we tell them that they have a positive alpha-feta protein test. And it gives their statistical data as to what their chances are of having a Down syndrome child. But we don't stop there, because I tell you why, there's a lot of false positives. You know, everything has to line up just right. You know, when you do your questionnaire with your patient, you know, you have to have the exact, they actually want the day of conception, they want the day of due date, mom's height, and mom's weight. And if she waits, if you give her the lab slip and she waits 2 weeks, it's not gonna be correct anyway, because she might have gained half a pound or a pound, and that's gonna throw off the test. A lot of times when I did my counseling with my patient, I filled out the form and I said, now go right now to the lab. Okay. And if it does still come back positive and you've done everything right, then we follow up with the amniocentesis, because again, that's most accurate. And if you're going to make some decisions, whether to continue or terminate the pregnancy, you want to make sure that it is correct. Okay. The worst thing to do would be to abort a baby if baby was just fine. All right, and here's my picture of my poor little guy with, my sweet little guy, I should say, because they are sweet. they're such loving children of a Down syndrome baby. And then, and here's your simian crease going right across the palm of the hand. And sometimes the finger, the little finger here is very much different than the other fingers. But this here gives you the simian crease. You can see that at birth. And then, of course, the low set eyes here. And another one, too, that's indicative, another characteristic is a protruding tongue. Their tongues just protrude over time. So what kind of manifestations will you see in a Down syndrome baby? They could be hypertonic. So their muscles are, they have no tone to them. So they're limp, maybe a flaccid posture, okay? They're sometimes difficult to position and hold because of the hypotonicity of their muscles and their bodies. There also contributes to heat loss because they don't have the ability to generate heat because of the hypotonicity of muscles. They're prone to respiratory illnesses, again, and constipation because of the hypotonicity. Unfortunately, acute leukemia is higher in this type of population of children. And they're saying that research have shown that Alzheimer's disease is more common to those who reach middle age adult life. Because they're living longer. And so now they're living longer, and now you can see they're doing research on that. And then you always want to encourage the the parents to express their feelings and concerns. It's not easy, everybody. And back before we did all these testing and alpha feta protein and all that, back in the 80s, we had more, undiagnosed Down syndrome babies born. And I had one incident, let me tell you, of a mom who refused to hold her baby when she saw that her baby wasn't normal. Yeah, it's very disheartening. And the parents left the child at the hospital. They didn't. And so we had to get some support from the community. We had to call, child services to come in, and they had to foster the child. So it's not easy. But, today we have the, alpha feta protein tests, which is good. And we have, of course, great amniocentesis tests. All right. So remember, there's always these milestones, and they'll do things, but it'll be at a different level than, say, a normal. They're able to help themselves. A lot of them are able to take care of, like, eating and toilet training and dressing themselves. And it's not such a stigma today. We see Down syndrome children or adults in, like, commercials. We see them out and about. We see them working. I know, like Goodwill we have here in Florida, they go ahead and take care, and we see a lot of children with Down syndrome having a job. And I think that's great. Okay. They're out in the public. Years ago, when you had a Down syndrome baby, you kind of kept the baby at home or kept the child at home and was not out about. So I think we've come a long way, and I'm happy to see that. So now, change gears a little bit, and let's go to the hemolytic disease of the newborn. It's called erythroblastosis fetalis. Now, it can happen. The real severe cases, we can pick up in utero, or we pick it up soon after birth. But remember, an Rh negative mother and Rh positive daddy produces what? Rh positive fetus. We know that maternal and fetal blood should not mix during pregnancy. But like everything else, it's not guaranteed that there may not be like a small leak that may allow that fetal blood to enter mom's circulation. When that happens, it's causing the mother's body to start producing those antibodies. They're there and they want to destroy something, okay? And what happens, they cross the placenta and they destroy the good blood cells, the erythrocytes of the fetus blood. Now, that fetus, because the mom's antibodies is tearing down those beautiful fetal erythrocytes or red blood cells, taking them down, boom, 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 all right? Then baby now is becoming anemic because he needs red blood cells. Red blood cells carry oxygen. He needs oxygen. So you have this baby has anemic. He can go into heart failure and not good at all. So here's our little drawing about the different cells going on. And you can see that here we have the Rh negative blood cells. That's a mom. And here we have the positives. Remember, negative and positives, they don't mix very well. No, they don't. And what happens here is that you see the antibodies that are coming across and they're going to destroy the fetal cells. Okay. And we have hemolysis of the Rh positive RBCs. And that's what causes the baby to be anemic. Okay. And we can combat that easily. Combat that. How we combat that? We can combat that with RhoGAM. Give mom RhoGAM. So again, mom accumulates these antibodies with each pregnancy. Okay, so when you're giving RhoGAM, you're protecting the fetuses. And we're protecting like when you give it like after delivery, like 72 hours after delivery, you're protecting with the next pregnancy. Because mom will accumulate these antibodies within her body with each pregnancy. And so you don't want to get severe forms of like hydrops fetalis. This is progressive hemolysis causing anemia, heart failure, fetal hypoxia because he needs the red blood cells for oxygen, like I said, so you get fetal hypoxia, and that's never good. So what are we going to do with diagnosis and prevention? Well, we want to know exactly at her first visit what her blood type is. So we're going to do a blood type, right? An RH. We want to know right from the beginning, is she negative? If this is her first baby, we make sure that we give her RhoGAM during the pregnancy. If this is her second baby, I always question, make sure that she received her RhoGAM after her baby, her first one, and that she had it with her during her other pregnancy. If she had any kind of ectopic pregnancy, she gets RhoGAM. Any abortion, she gets RhoGAM. Has she had a blood transfusion? Or did she have a child who developed jaundice or anemia during a neonatal period? This is your pathological jaundice, which is never good. And so a lot of times we'll do like we call a Coombs test. We can do an indirect Coombs test, which will indicate previous exposure to an Rh positive antigen. So you can do that test to find out if she's had any kind of previous exposure to any kind of Rh positive. So maybe from her other pregnancy, you can do it called indirect Coombs test. So how is this diagnosed? Well, it's confirmed by amniocentesis and monitoring of bilirubin levels in the amniotic fluid. Now, we can determine if this baby is anemic in utero. And they can do, guys, an intrauterine fetal transfusion. Very risky. I think in 45 years of my nursing, I've seen it one time, and I tell you what, it was nerve-wracking. I was not in the NICU, working in the NICU, but I knew it was happening. Okay. We're going to get this. If we know this baby is having problems, we can go ahead and get the baby out by doing maybe a induction of labor. Get this baby delivered so that we can get in the NICU and we can monitor the baby and do a transfusion right away in the NICU. It is a serious complication. And it's easily handled, controlled by the use of Rogaine. So it's administered within the 72 hours after delivery. So before she goes home, she gets Rogaine. And I told you every time she has an ectopic or after an abortion, where she's exposed to an Rh positive antigen, she's going to get a Rogaine. Okay. And then she gets it during the pregnancy. Remember, I think you can remember, is about 28 weeks gestation. We're making sure that mom's antibodies don't get this baby. Okay. And then after the baby's born, you can do a direct Coombs test. The direct Coombs test is on the umbilical cord blood. Okay. So you have one indirect and you have one direct. Now, symptoms. Anemia. Okay. Again, hemolysis of large number of erythrocytes. Okay. Red blood cells. Pathological jaundice, write this down, can occur within 24 hours of delivery, and the liver cannot handle the amount of the hemolysis. There's so much destruction that's gone on with the red blood cells that it builds up, and the liver can no longer break it down. So the bilirubin levels then will rise very quickly. Not a good thing. So you have enlargement and edema of the liver and spleen. And then oxygen carrying capacity. Remember I said erythrocytes have carrying oxygen. So if you don't have them, then the amount of oxygen is definitely diminished. So then your baby gets into hypoxia. And then these kind of babies, because you got to have red blood cells, they're at major risk of shock or heart failure. Not a good thing. A serious condition. Okay. So what are some manifestations? You can get kernicterus, where the bilirubin now has reached toxic level. Now, an increase of bilirubin in the brain tissue can cause serious brain damage and causes a permanent disability. So you want to break that down quickly. And we break it down quickly with phototherapy. So infants that will have jaundice will also they are extremely irritable. They're lethargic. If you notice, that's a going trend with babies. Poor feeders, they won't feed. A high pitch, this is a shrill cry. Muscle weakness. And they have seizures. Not good. So what are you going to do? What's your treatment? Well, promptly, you're going to identify these babies. Laboratory testing and phototherapy is the big one. And sometimes exchange transfusion if indicated. Now that's a big one. That's not taken lightly. That's not a big, how we really get is with phototherapy. So what I want you to get from here with a baby under phototherapy, these are bright lights, guys, ultraviolet lights that are on the baby. So the baby's like in an incubator with all these lights on it. It only has on maybe a little bit of a diaper, because, for the excretions, but that's it. But if you're under bright lights, you've got to protect the baby's eyes. Okay. It's just like, I don't know, I can equate with Florida. Florida, we have really bright sun, okay, especially during the summer months. You wouldn't be caught, you could not go on the beach without sunglasses, okay? Because the light, ultraviolet light from the sun is so great, it can really hurt your eyes. So we want to make sure that these babies' eyes are protected. And we have a nice little eye patch that goes on their eyes. They're not happy about it. they work really hard to get it off, but the nurse is watching the baby very closely, so she makes sure that baby's eyes are protected. You always want to cover on the little boys, the gonads. The baby's an incubator. And sometimes these babies have what we call a central line. And that's where we go right through the umbilical vein. So on these kind of babies, we would not cut the cord so short. We would leave more of the cord so that we can use that umbilical vein to put in a central line for these babies. We always look at the baby's color. We can tell if a baby's getting yellow by looking at the whites of their eyes. They'll turn yellowish. And then any over bony area, you blanch down and it stays yellow. Okay, you want to pick it up very quickly. You don't want to get time is of essence. So let me see. It's crazy here. Okay, let's go on here. Like I said, jaundice is that occurs. Write this down. Pathological jaundice occurs on the first day of life. Okay, pathological jaundice, and it always, guys, requires prompt intervention because the liver is involved. So your liver, you do a blood test, your liver enzymes would be very high. So pathological jaundice is always a bad problem and requires really prompt intervention. Okay, I already told you about assessing jaundice, and you look at the skin and the whites of their eyes, and it has like a yellow-orange cast, and you go over bony prominences and enhances the evaluation of jaundice. Okay, so I got a picture of a little guy here. Here we go. He's poor little thing. He's a little jaundice, isn't he? So here we go. Here's your phototherapy. Now, do you all see these bright lights? Everybody? Yes? You still with me? Hello?
Yes.
Okay.
Yes.
Okay. All right. So you see it's an incubator. See my little guy here? See his little cover over his eyes? That's imperative. You don't want to burn his eyes with these big bright lights because he's laying there. And he's like laying there all exposed because you want to get the bright lights on the skin. You want to break down that bilirubin. So you want it. So he's going to excrete his bilirubin through feces and through urine. So that's how you'll see it. And so you want this to get out. Okay, this can be very scary for a mom to see, but we explain to them what's happening and the reason. And we give the baby plenty of fluids. And so that, again, he will have excretions. Here he is here. And I thought this is a really nice way of making sure that the eye patch, the covering stays on. That netting that we use in wound care, you can put right on over the head, okay? Again, the baby's got to be watched carefully. Never, you can't leave this baby alone watching it. Now, hello? Ashley, do you have a question?
No.
Okay. So, now if a baby has mild to moderate physiological jaundice, I put that in parentheses, a more normal jaundice, if we want to say, because a lot of babies do get jaundice, correct? So you see that happening. And then they can go home with these little billy lights. And you can see here's one at home with the little billy lights. And this is a billy blanket. Oops, sorry about that. My little picture here. Okay. So you can use these. It does decrease the need for hospitalization. But if this baby has severe high bilirubin, you probably want to have the baby in the hospital with these kind of lights. Okay, because there's a difference. But in Florida, we just tell moms to take the baby out for a walk. and have the baby exposed to the sunlight. Okay. All right. Now, another problem we can talk about is intracranial hemorrhage. That's the most common type of birth injury. Okay, which is not nice, it's not good. It can result from trauma or anoxia, and it occurs more often in preterm infants because the cranium is what? It's not as hard and formed as a term baby. Okay? You have to be careful with preterm infants' head because of the intracranial hemorrhage. That's why a lot of pretermers are born cesarean so they can be lifted up instead of them going down the pelvis if they're pretermers. Remember I told you about precipitous delivery? Okay, the baby is coming down very quickly, so that's labor and birth all within 3 hours. That baby's coming down the pelvis, the passageway, right? Real quick. It's like he bangs into like into bones. You know, I don't know if you ever been to like a little carnival and they have those bumper cars and you know, you bump into each other. Well, that's how I, see a baby's head coming down really, really quick. He just bumps, bumps, bumps. Well, what's happening is that he's bumping his head. And, there's blood vessels in the head. And so he can cause those blood vessels to open up, to burst, to hemorrhage, to bleed out. So that's never good. Or if mom has a prolonged labor, that can also happen. So if she's pushing a long time, that can happen. Is that, it's just the head of a baby is so soft and it's fragile. It can bleed easily. So we don't want those things to happen. Now, how are we going to diagnose this? Well, we get a history. Have we had a traumatic delivery? Traumatic where, you had, not only precipitous, but maybe you had forceps, okay? Years ago, they used to do high forceps. Thank goodness we only do low forceps now, but they used to pull babies out. And so you have a traumatic delivery. You can cause the cranium to hemorrhage. You can get the CT or MRI scan to, confirm intracranial hemorrhage. And then you'll see evidence of increase in cerebral spinal fluid pressure. How are you going to treat this? Well, oxygen, gentle handling of that baby, okay? And you keep the baby's head elevated up, okay? Medications may be prescribed and care with feeding because with intracranial hemorrhage, they could lose that suction reflex that they need. And so it can be affected because of the intracranial hemorrhage. So you have to be careful. Okay. If you're taking care of a baby and the baby has a convulsion, you must call the physician immediately. So, and be ready. I think this is a good thing just to know for anybody, be ready to answer the following questions. Because if you call a doctor with a report of a convulsion, he's always going to ask you, were the arms, legs, or face involved? Was it the right or left side of the body involved? Was the convulsion mild or severe? How long did it last? These are typical questions for anybody who has a convulsion. You're going to give an SBAR report to a physician. He'll want to know that. Then the next one for infants would be, what was the condition of the infant before and after the seizure? Okay, like, what was his vital signs before the convulsion? What did his skin look like? Was the skin assessed for increased bilirubin? Was he experiencing already having jaundice within the first 24 hours? This is what we're looking at when we have a baby who has a convulsion. Okay. So now the next one we're going to talk about is just what we call tachypnea. Okay, and what it is transient tachypnea of the newborn. That's called abbreviation TTN. It's also been referred to in my day as respiratory distress syndrome type 2. What happens? Remember I said chest retractions are never, never good, right? So write that down. Grunting. When you hear a baby grunting, making those noises, never, never good. And if the baby is turning like cyanotic, is not good. Okay. So what we're going to do is we'll treat it. We'll give the baby some fluids. We'll make sure he gets oxygen, and hopefully, and everything will resolve in after 3 days. Wonderful. What happens sometimes that causes, that's what we call a transient tachypnea, is because babies are born with a lot of fluid. It could be a lot of fluid in their lungs. And so, and they're not able to get it all up. So they increase their respirations. But when they do that too, because they're trying to get air, their little chests will retract. You'll see the chest retractions. And of course, they're going to have that grunting noise. And they need, they need some nursing and medical intervention. So we'll watch them for a good 3 days. And usually, because you get the fluid out, a lot of times RT will be called, respiratory therapy will be called to get the extra fluid out. Okay. Then you have, the next one I'm going to talk about is Meconium aspiration syndrome. So in utero, the fetus can, if it happens in utero, it expels meconium into the amniotic fluid. Well, we've gone over that before. You have the meconium, remember on assessment during labor, you see the color of the fluid, and it's got that greenish, brownish, tinged looking color fluid. The baby had his first bowel movement in utero. Okay. When babies are born, we have to suction them out very quickly. And so, because we don't want them to take their first breath, because if they take their first breath before we're able to suction them out and deep suction them, they can aspirate the meconium into their lungs. And so they become very sick babies. So we want to make sure that these babies are suctioned. Now, so for instance, the head is delivered. So we're using wall suctioning. We get the wall suctioning, get the trocar, and we're going to go ahead and suction as much as we can all in the mouth, okay? Okay. Now, the rest of the body comes, okay? We got the baby in my hand. We take it over to the radium warmer. RT is there along with the NICU nurse, and the RT will intubate that baby and then put a tube down, and he'll suck all the way up from that stomach, all the way up. Okay. And so we want to get all that up before the baby takes his first breath. Now, even with all this intervention that we're doing, the baby will go to NICU for precautionary measures to make sure that we got it all up, okay, that he doesn't have it. It's not good to have meconium aspiration syndrome. We do everything we can to avoid it. And because the babies can get very, very sick for taking that into his lungs. You see the babies in the NICU, they're really sick. They're on all kinds of monitors because of the meconium going into the lungs. Okay. Because don't forget, meconium is baby stool. There's probably vernix in that meconium stool. There's also langugo, those little fine hairs is in the stool. So all that icky stuff, right, can go into his lungs, cause a massive infection in the lungs. All right. So these are your symptoms. You have, of course, respiratory distress, the nasal flaring. I would write nasal flaring now. Nasal flaring, that little nose, they just flare right up. You can see that. That's a baby having problems with breathing. Retractions, grunting, cyanosis. You can hear, when you take your stethoscope and assess lung sounds, you'll hear rhonchi, you'll hear rales, and of course, they have tachypnea. So what are you going to do? Treatment. Well, we're going to make sure we suction this baby out properly when it's born. You're going to provide warmth. Remember, thermoregulation. Don't cold stress this baby out. Give oxygen. And of course, would be in the NICU. It has to have supportive care, definitely, for the mom and dad. Okay, the last one I want to talk about is neonatal abstinence syndrome, because you'll probably see this on exam number 3. All this will be on exam number 3. So it's caused by fetal exposure to drugs. We talked about this already in utero. Okay, because these kind of drugs, the low molecule kind of drugs, they do cross the placenta barrier. So when an infant is born to a woman who's addicted, they will suffer the same kind of horrible withdrawal after birth. They're very, very irritable. You know, you can't even hold them, and you think you can swaddle them and just hold and rock them. That rocking motion will irritate them. So what the best thing to do is just swaddle them up and you put them back in the crib, and a lot of times we'll give them some medication to decrease the irritability and maybe make it a little calmer. But these babies can have long-term developmental and neurological defect because of that. So, what are your symptoms? Body tremors, definitely. Hyperirritability is your primary sign. That's what you see most of all. They don't go to sleep. They're always awake. They can experience diarrhea. They're poor feeders. Yeah, they're not interested in feeding. Their body, like an adult who's addicted, is looking for the drug. They were getting those drugs fed to them while they were in utero, and all of a sudden now they're born, the drug is cut out, and so they are having a tough time. They're not interested in feeding. Sneezing is another sign that we see. Sneezing. And then another one I thought was interesting is yawning, and I thought that was interesting. When you're going to test for this type of situation, the Meconium is more reliable than a urine test. Well, okay, because that probably has more of the drug than probably urine. So it's more concentrated too. Treatment. I talked about swaddling because it's highlighted there, right? Okay, we're also going to have this baby in a quiet environment. Observe for seizures. These babies can have seizures, so we'll probably give them medication such as phenobarbital to combat. That makes them quieter. It takes down some of the hyperirritability, and also will help prevent a seizure. Okay, because you don't want these poor little things to have seizures on top of everything. Okay, so now we have the infant of a diabetic mother. Okay, another problem. So again, remember, large amounts of glucose can go right to the fetus. So while the baby's still in utero, the baby's blood sugar can increase, be hyperglycemic. And during the time the baby's in utero, his little pancreas is probably trying to keep up with the large amount of sugar by giving out large amounts of insulin. So what happens is that you can at birth have a situation with hyperinsulinemia, along with excessive production of protein and fatty acids, which also results in an LGA baby. This is called a large for gestational age newborn. A baby weighing 9 pounds or more is called a macrosomic baby. Okay, so because in utero, you have this hyperinsulin, you have hypersugar environment, that's what produces this big baby. Okay, now when the baby's born, the sugar is cut off, right? Boom, it's cut off. Let me just go here. So the infants then say, well, where's all my Snicker bars? Oh, well, she's not feeding me anymore. No, you're born. So you could have now this baby has his blood sugar that goes way low. So now you have low blood glucose levels. And what the baby can look like is called a cushingoid appearance, as like a moon face. Okay. They may look healthy too, but usually they have this big old round face, and it's compared to what we call a moon face. Also, they can have developmental defects, and they can suffer complications of respiratory distress syndrome. Now, baby could have hypoglycemia, could have hypocalcemia, low calcium, and then have hyperbilirubinemia. This is a sick baby. This baby's got to go into the NICU in order that it can have his blood glucose levels looked at very carefully, and his blood sugar, right? Blood glucose levels, and his calcium, and his bilirubin. This kind of baby with hyperbilirubinemia can get what? Jaundice. Okay. So what are we going to do? Well, glucose levels, like I said, we're going to take care of his baby, make sure his vital signs are normal. Going to look for signs of irritability, tremors, and respiratory distress. Okay. You don't want to cold stress this baby out either, because this baby has a problem already with hypoglycemic. And if you cold stress this baby out, you're definitely going to get a baby that has low blood sugar, and it's going to lead into respiratory distress. You do not want to have those two going on, because he can have respiratory distress just from his what? Low levels of glucose. Okay, so glucose levels that fall below 40 micrograms, milligrams per deciliter can result in a rapid and permanent brain damage. Now, remember the other day we talked about 45 milligrams per deciliter? And I said some books have 40, some have 45. But if it goes down below 40, guys, you can have brain damage to this baby, which is never good. Okay, so here we have, that's all I have for chapter 14. So we went over a lot of information today, and I'm hoping that you took really good notes and that you use your book as we were going along, because it was really verbatim from your book. And then be sure to do your key terms in the beginning of your chapter. And then look at, read key points. And I hope that during this time that you have been in maternity, that you've been doing that unfolding case study. That's a pretty good case study, by the way. So I think you would enjoy that. And now you can see what you're up to with the baby. Okay, so we're almost done with time. We have 7 more minutes. Anybody have any questions over the information that was given to you today? Okay, everybody really got a good hold on chapter 14. Also, be sure to read chapter 13. It's on preterm and post-term infants. And be sure that you read about how to feed a premature baby. Okay, we use what? Gavage feedings. I'm sure that you go over that in your reading. And then during this week, we'll have plenty exam reviews. Okay, plenty exam reviews. Do attend them. I know they may be long, and you may think, it's too long. Do as much as you can, and maybe do intervals. Speed me up, speed anybody up, okay? Shut me down when you get tired of listening. But listen, attend them. They're there for you, and they will help you with exam number 3. Okay. Well, we have 6 minutes to go. Anybody have anything? Go ahead.
When is the review schedule going to be put up?
I'll look for that today.
Okay, thank you.
Wait, when the next exam? Next week or the one after that?
No.
Next week.
Barbara, next week.
What
It's right around the corner. So this was your last quiz. Your exam number 3 is next Monday. So it's coming to an end.
On what chapters?
What, exam number 3?
Yeah.
Look over, let's see. Let's get your syllabus. This is what I do.
I don't got no syllabus. I gotta find it.
Oh, that's okay. Exam 3 covers weeks 7 and 8. Now, week 7, we had chapter 10. We had the nursing care of women with complications after birth. Chapter 12, the term newborn. Chapter 13, preterm and post-term newborns. And chapter 14, which we just did today, the newborn with a perinatal injury or congenital malformation.
Okay.
Now I can tell you, spina bifida, hydrocephalus, diabetes, a diabetic mom, macrosomia, respiratory distress, cold stress. I'm just trying to think on top of my head. Those are all highlights, okay? So you really want to know them inside and out. All right. I will be reading your discussion question number 3. And I will be doing that and also looking at this doses calculation worksheet number 2. Okay.
Are you putting this up tonight? Are you putting this recording up tonight?
Yeah.
All right. Thank you.
Oh, you're welcome. All righty. Chanel, are you, it looks like she's talking. But anyway, she must be busy. I hope she's listening to me. Okay. Let's see. We have 3 more minutes. Anybody have any concerns? How'd you find quiz 5?
It wasn't bad at all.
Okay, thank you, Barbara. Okay, good. I'm glad. I hope
You
you
said
all
the
made
homework
I hope you all made 100.
Oh yeah, the homework gotta go off because it's throwing me off. That might not be what I got.
Well, now I will leave up for a couple more days the homework up, and then I have to discontinue. I have to take it down. I'll probably take it down on Wednesday. Now, I did ask you to contact me to meet with me this week.
Okay.
You don't have to meet with me long, just a few minutes, just so that we touch base. So you tell me the time, and I'll make it work.
Is that for everybody?
Everybody.
Okay.
I want to make sure everybody's prepared for exam number 3, and you will be, okay? You will be. And then, of course, after that, we get ready for the HESI. And I do a comprehensive review for HESI. And I already have a HESI review on YouTube, and I'll make that public for you. I will send out a blueprint.
So do you email to book an appointment for the meeting?
Yeah, just send me an email. Yeah. Sure. I usually like to shoot for Wednesday and Thursday, okay?
Okay.
Now, I am going to send you a blueprint to help you with exam number 3.
Okay.
It's comprehensive. You got to look in the book. You got to go to your notes. You got to go to the PowerPoints. But it's good. Okay. All righty. I just lost Chanel. Where are you? It's got 1 more minute to go. All right. Everybody feeling good? Yeah, good. All right, good. Just tell yourself, you got it. You can do it. It's almost over. All right. I'm going to say good night to you. It's almost 5:30ish. What do you got? Anybody have 5:30?
So we should email you for
Yeah.
like a meeting.
Yeah, email me for a time. And if it's already taken, I'll tell you and we'll just make it for either 15 minutes.
People?
You know, either way, okay? But email me.
Okay.
Yeah.
All right.
All right.
All
Okay,
right.
y'all. I think
Bye.
it's 5:30 now.
Good night.
Keep reading. You got this. You got this. Good night, y'all. Good night, everybody.